All right, welcome everyone to the Scientific series. Bonjour tout le monde, bienvenue à la série Scientifique. It's a pleasure to present Dr. Dasgupta, who I've known for a long time, but it was a different kind of feeling to read the bio and find out about all the great things you've done. Dr. Dasgupta est professeur titulaire en médecine à la faculté de médecine de l'Université de Montréal et chercheur titulaire à l'unité CORE, Clinical Outcomes Research and Evaluation of the MUHC-RI. She is a graduate of the McGill Medical School, completed her internal medicine training a few years ago. Par la suite, elle a complété sa maîtrise en épidémiologie. Between 1997 and 2002, she practiced as a general internist in Amos, Quebec. That's a very confidence-building kind of...
It is. It was fantastic practice, yeah.
She then returned to McGill as a physician-scientist in 2002. Her research focused on prevention, remission, self-management, and diabetes. She's held numerous grants, starting with CIHR New Investigator Awards and the entire FRSQ Clinical Scientist Suite from Junior 1 all the way to Senior, which is quite impressive. She leads studies funded by CIHR, Heart Stroke Foundation, Lawson Foundation, Diabetes Canada. Ces publications reçoivent beaucoup d'attention médiatique à cause de leur pertinence aux patients et de leur impact au niveau des politiques de santé. Today's presentation will be in English. La présentation d'aujourd'hui sera en anglais. And it's titled Activating At-Risk Pregnant Persons Through Step Tracking and Weekly Targets to Reduce Adverse Outcomes and Cardiometabolic Consequences. Study Design, Methods, and Methods.
Thank you, Ari. Thank you for having me. Wow. And I would be amiss if I didn't introduce my partner in research, Debbie Chan. Yeah. Has worked with me for well over 20 years now, and nothing would be possible without Debbie. And Deborah, who's also a member of our team. I only hire people named Deb. So Deborah's been working with us for a couple of years now, and she's going to be going on to do a master's in public. If you don't mind, just to get a feel for the room, broadly, who are you and who are you? Go ahead.
My name is Kat Cha. I work at research for
Okay.
Researchers with subventions and articles and.
Okay. So who are research managers and research assistants? Raise a hand. The room. Okay. And who are researchers? Everybody else? And who are clinicians? Okay, so I have a sense now. I won't ask the people if there are online. So I asked me to talk about this study, which is our new trial. Do we need to do anything for any online people? No, we're good. So this has not started yet, but it's still going to be fun to talk about, and we'll have lots of time for questions. And we're hoping that St. Mary's, being the largest delivery center in Montreal, will be, a key recruitment site. So we're going to review, I'm hiding from Debbie, but that's okay. She sees me enough. We're going to review the role of physical activity in pregnancy and the related guidelines, and then we're going to talk about how we designed APOC and some interesting aspects like the ranked composite outcome, the win ratio. These are becoming more popular. And then I'd love to chat with you about recruitment here. We do have partners in strictness and medicine, but you all have sort of notions of how to do things here. So I'm looking forward to that conversation. I'm an active socialist and I don't take money from anybody that's not publicly funded. So we're going to first where did my objectives go? Did I lose them? Oh, maybe they'll appear. Anyway, so we're going to just do a little overview of gestational diabetes, gestational hypertension, and preeclampsia and related complications. And then we'll go on to physical activity in pregnancy, the intervention we designed, the trial design, and where we're going to go from here. So just in case, just to get everybody on the same page, gestational diabetes is new onset diabetes in pregnancy. So it's people who you think largely didn't have diabetes before pregnancy. They might have had prediabetes, but because of the body changes during pregnancy, the placental hormones, they start to develop more insulin resistance on top of their perhaps underlying insulin resistance, and they manifest higher blood sugars. And so in Canada, we have universal screening at 24 to 26 weeks of pregnancy, and there are different ways to test for gestational diabetes in Canada. There's 2 endorsed options. They all rely on ultimately getting a load of glucose and then seeing what the glucose levels are, just before and after. And there's thresholds for positivity that are slightly different depending on the method. But in general, if you take people with gestational diabetes, it has important impacts during pregnancy. So for the mom, it can increase the risk of preeclampsia, which we'll talk about, which is higher blood pressure in pregnancy accompanied by damage potentially to the mother's organs. But those high sugars of pregnancy kind of overnourish the offspring, can become larger and therefore needs for C-section, injury during delivery. There's high risk of postpartum bleeding and various offspring health outcomes, including preterm delivery, high birth weight, but sometimes low birth weight if there's enough placental problems. And so you may or may not be aware of these respiratory distress syndromes. So some bad outcomes that we would like to avoid. And then we have high blood pressure in pregnancy, gestational hypertension, which has a parallel definition. It's new onset during pregnancy. Usually in pregnancy, our blood pressure tends to go down a bit, but here, thresholds are similar to what we would have in the general population. And preeclampsia, which is this elevation in blood pressure compounded by some evidence of placental dysfunction, maternal organ dysfunction, and there are a variety of criteria for that. And of course, there are impacts of having, by definition, preeclampsia with impacts in the brain, seizures, strokes, headaches, pulmonary edema, so water in the lungs, problems with coagulation, so the blood cells, blood vessels, kidney injury, and then the baby can be impacted with fetal distress and growth restriction. So definitely something we want to avoid and one of the leading causes of maternal death. And then there are longer term outcomes. So if you have either or both or any of those 3 conditions, not great during the pregnancy and in the immediate follow-up period, but in the longer term, the women who develop gestational diabetes, even though it resolves generally soon after pregnancy, are at higher risk of developing diabetes. Preeclampsia predicts higher risk of hypertension, and both of them predict higher risks for stroke, vascular disease, as do some markers of fetal health. So the more of these issues you have, the higher the risks. And obviously we want to prevent all of that. And we've done a number of studies, epidemiological studies in this area. That was my former PhD student and my current PhD student. So we had a number of studies. These were Heart Stroke Foundation funded. And what we did in those studies is we looked at people with 2 pregnancies and looked at different patterns of gestational diabetes, gestational hypertension, and if you had more episodes. So did you have gestational diabetes in both pregnancies, or preeclampsia in one and gestational diabetes in the other? Was that worse? It's sort of a dose response. And we found indeed that it was. So if you had more episodes of gestational diabetes, you were more likely to develop diabetes in the future. If you had more episodes of gestational hypertension or preeclampsia, more likely to develop hypertension in the future. And if you had more of both or either, there was increased risk of myocardial infarction and stroke. So definitely something we want to avoid. And physical activity is one of those things that can be helpful. So this is just a little snapshot of a systematic review that was a Canadian one, actually, Maggie Davenport, Michelle Matola, and they basically looked at it's a meta-analysis of various exercise interventions, and they looked to see, what were some thresholds for risk reduction of gestational diabetes, gestational hypertension, preeclampsia. This is just the duration. So you can sort of see above the green line, which is above, somewhere between 50 and 100 minutes per week, there was at least a 25% reduction in each of those things. But there were also issues around intensity, frequency of activity. And they distilled all of that information to conclude that definitely all women who don't have a specific reason that would endanger their health or their baby's health, they should be physically active throughout pregnancy. and that they should accumulate at least 150 minutes of moderate intensity, moderate to vigorous intensity physical activity each week to have impacts on their health. And that could be accumulated over 3 days minimum, but ideally it's a bit of activity daily. So that is in the current guidelines. And I feel like fans. So now, in fact, in their review, once they did all of their sort of calculations, it was 140 minutes per week that was good, but 150 goes with our regular guidelines, so why not? And we translate that into 140 minutes translates into about 6,500 steps a day. So kind of keep that in mind as we move forward. And there have been other reviews that have interestingly looked at offspring health and efficacies of exercise only and exercise combined interventions. And there are signals that, certainly with the exercise focused interventions, that there can be optimization of birth weight, perhaps also preterm birth being less likely, small size for gestational age, large size for gestational age, even later childhood outcomes. They're close. Some of them are not quite significant, but they're all kind of going in the right direction. So suggesting that the impact is beyond mom's health and potentially favorably impacting the offspring. So that brings us to APOC. Worked hard on that. Used AI for the first time. Came up with something, and then my kids, both of them are adult men now, said, "Oh my God," and then they changed it. So there's so the question that we're asking is, among people with a singleton pregnancy who, when they come in, are under 22 weeks gestation, we're actually hoping closer to 12 weeks gestation because we want to have a lot of time, and who have any combination of pre-pregnancy excess weight, so they don't have to have been pregnant before, or previous gestational diabetes, previous gestational hypertension, or preeclampsia. So that group of people, does giving them a step counter and send weekly goals compared to just giving them a step counter, will that reduce bad things? Now, these bad things are gestational diabetes in that pregnancy, preeclampsia, gestational hypertension, small or large size for gestational age, preterm delivery, a variety of fetal or neonatal or maternal mortality. So it's a composite, but we're going to talk about that. Does that improve things? So that's the goal of this study, because we have studies that have focused on different kinds of exercise interventions, sort of individual outcomes, but here we're really going to try to bring the literature together and look at everything at the same time. Yeah.
How many pregnancies, like when you have multiple pregnancies, if you have gestational diabetes first time or even whatever, how many do not have gestational diabetes in subsequent pregnancies?
About 50-50.
Okay.
Yeah, it's about 50-50. It's kind of interesting because I have one colleague who tells me, like, a friend of mine from Toronto, and he says, "Oh yeah, it's because," and he'll attribute to physiological differences. I think it's because some people get GDM. They actually work hard to not get it again, and we don't.
It really depends on your patient. So I follow pregnancies, and and it really depends on the patient population.
Yeah,
their socioeconomic status is a huge factor in it. So that my patients with a lower, and it goes with the data.
Yeah.
Lower socioeconomic status. If they have GDM in one pregnancy, they have a higher chance of having GDM in subsequent pregnancies because they're not able to control, eat better, take time off work, or any of this. So,
that's absolutely true. And so you are at higher risk, but it isn't 100%. I think that's what surprises people. Yeah. No, it's true. So this is a study funded by the CIHR. We have collaborators here. We're under ethics review right now. I adapted our recruitment materials for clinicians, but that's not our actual, material. But it's, we're looking for people, as I mentioned, the inclusion criteria. And our goal is to recruit about 600 people per year for around 3.5 years to have enough time to follow everyone up. It's a 4 to 5 year study. We have sites in 5 cities, but really, as is typical for us, Montreal tends to be our bigger site because that's where we live. And the McGill system is kind of our focus. So this is what we're looking for. These are the kinds of materials. Once they're approved, there's going to be posters, and then there's going to be a landing page where people can go. But of course, it's actually going to be through the clinics where the majority of our recruitment tends to happen. So putting it in a PICO framework, so among women under 22 weeks of pregnancy, with obesity, living with obesity, or past history of any of those conditions, will the step counter, which right now is a Fitbit and will be, but we have enough flexibility that if something happens to Fitbit, we'll be able to switch it around. Plus weekly targets versus step counter only, will it reduce this composite endpoint? And so, what will they be doing? Well, the group with the step counter alone, they can use it as often as they like. Our goal in giving it to them is to actually measure their physical activity, so we have that comparison to see if there's a difference. So we really ask them to wear it for 7 days as soon as they join the study, after their GDM screening later in the pregnancy, a couple of weeks before delivery, and then 6 to 12 months after delivery, and about 6 months after delivery. So we'll know at those time points. But if they wear it more, so much the better. If they use it for their own target setting, terrific. That's because that's the real world of what happens. But the other group, we're going to encourage them to wear it all the time, unless they're bathing or swimming here in the water. They don't have to wear it when they're sleeping, but if they do, that's great. And they'll get targets every week. And I'm going to show you how we figure out the targets. And they're going to wear it up until, delivery. And then after that, we don't send them targets, but they will wear it again 6 to 12 weeks after delivery, and then around 6 months after delivery. So we see what happens to their activity. So how do we set the target? So we will have a first week where they wear it without a target in the intervention arm. And then depending on the range of their step counts, we will set kind of a first week target or a baseline target. So if you're in a very low activity category, under 5,000 steps per day, that first week, we're just going to suggest you increase by 500 steps per day. If you're already like 9,000, 10,000 steps, you're more or less maintaining or slightly increasing. And if you're somewhere in between, we'll encourage you to increase by 1,000. But thereafter, every week it'll change. So if you go up more, the target increase might be more ambitious. If you go down, we'll be more modest. So we're following them, kind of always nudging a bit upwards, but not giving someone an under 5,000 steps per day baseline, a 10,000 target, which I think is where many interventions fall off because you wind up discouraging people. And so this is in the background of what we're doing. So we have that baseline, steps, and then we set that first week's target. And every week, iteratively, we might be going up by 250, we might be going up by 500, we might be going up by 1,000, or we're, telling them to. It depends on what their base category is that they now land on, and whether they reached the last week's target, and we kind of work that way. And we actually did a feasibility trial. The feasibility trial was in 227 women who had gestational diabetes. So that one was not as early in pregnancy, but we wanted to test out this approach. And in that study, we did a couple of things because it was our opportunity to see what could work. And we actually did this kind of step count target. And then we had another group where they didn't have step count monitoring. They had coaching, weekly calls. And then we had another group that had both, and we had another group that had neither. And we wanted to see, did people say 2 things were too much? Did they say they loved the coaching and, that was perfect? Did they say, what was the combination? And interestingly, in the end, the ones with just the step count targets had maybe not surprisingly, the best outcome in terms of steps. Coaching did better than the control group, but not as well as the steps only. It may have been that they wound up doing other activities that weren't captured as much by step counts. And it was the same for the combined coaching and step tracking alternative. So what we found overall was that everybody kind of started at around 6,000 to 7,000 steps per day, similar between these two arms that I'm showing you. But while the people without the intervention dropped by about 1,400 steps per day, the people on the track and target group, they stayed they maintained. So they stayed at that 6,500, 6,600 steps per day, which, as we saw before, is what's recommended. And I'm just showing this other line, this is the step and weight tracking, because we did weight tracking, which seemed to make a difference. Everybody had GM and everybody was careful about their dietary intake after that. So, but what was interesting is that people didn't tend to necessarily meet the target we set, but we think that by having that target, they maintained. So that, that we saw down the line. So that we do know. So in APOC though, we found we could impact step counts, but if you do it in gestational diabetes, you have literally 6 weeks to work with, which is not a lot. So it's not a lot to improve outcomes. So our decision was to go earlier in people at risk and see by doing it longer if that has an impact. Because you can imagine a situation where sort of like mid to early end of pregnancy, you're active, then you decline, because people do decline during pregnancy. Those of us who've been pregnant, I already won't know, but the rest of us, the rest of us might, some of us. And so that could have a favorable impact, and that's what we're trying to catch. It's not just the steps by themselves. So we're going to try to invite people ideally around their first pregnancy clinic visit, but it could be around their first ultrasound assessment. It could be other pregnancy clinic visits or assessments. There will be some self-referral, I'm sure. It'll be though at our sites, because we do need access to charts and so on. So, St. Mary's, MUHC, the Jewish General, and other places. But, and so they will signal interest through their referrals or how they come in, and then what we do is we can send them by phone to keep it simple, and then we do an eligibility questionnaire on the phone, and we would review the charts to make sure all is good, and then we start going. They do the online questionnaire, we randomize them, we mail out the step counters. We will mail out the step counters to everybody. Then there'll be a conversation, probably Zoom, but it could be a regular call. Sometimes it could be in person if that's more convenient, and we'll show them how to use it and what's involved. And once they finish that first week of use in both arms, they'll get a gift card. So there's certain points, like I mentioned for the control arm, where they'll get a gift card, but we'll also give the intervention arm. There was a big debate between Debbie and me. I'm like, but the intervention arm's getting the intervention. She's like, no, it's not fair. I'm like, okay. So they both will get gift cards. And so the criteria: singleton pregnancy under 22 weeks when we randomize, and if they are at the border, we have to decide, because we want them to be under when they start. So, but hopefully again earlier. They can't have a contraindication to physical activity, and at the time they come in, they can't have already been diagnosed with gestational diabetes or gestational hypertension or preeclampsia. But once they're in, if they develop GDM or just simple gestational hypertension, they can continue, because there's other outcomes that we're trying to prevent. Preeclampsia depends on how severe and what their treating team thinks. And they need to have a phone, which 95% of the population actually has, and at least one of those preconditions, which we talked about before. So contraindications, so they can't have a ruptured membrane, confident cervix, can't be in premature labor, already have fetal growth restriction, anything that their physician thinks could be a problem. We have to be careful, and we're going to stay in contact. And then during the pregnancy, so the intervention arm will get those step goals every week. The control arm will use at those specified time points. The pink indicates each time point that they get a gift card on completion of things. And we continue to review the charts regularly to gather outcome data, to also gather these intermediate endpoints: what their blood pressure is, what their weight is, what their blood sugar is. We certainly need them to have their usual gestational diabetes screen, and we will abstract that information. So that we will continue to do. And then after delivery, we do a careful hospital chart review, because there are all these outcomes that we need to look for. And so that will be the main part. After their delivery, when they come in for their follow-up visit with their physician and medical team, If they come in person, we'll come join and kind of ask some questions and do a little interview. And we will assess the A1C thinking with a fingerprint test, and we'll take it up. If it's a virtual visit with their clinician, then we'll arrange a visit either in their home or at a study center. And then 6 months later, we'll do the same thing, but we know that they may or may not come see their physician, so we'll go see them and see what their physical activity is, what the health of their baby is. So that's the general design. And you know, it's interesting because while this was a big grant, they still cut us by a huge amount. So we kept it very deliverable. We cut out any extra bells and whistles in terms of, you know, proteomics and genomics and extra blood tests and stuff. There's versions. Like that, yeah. So, and I actually, at the end of the day, sometimes when you do that, you're like, okay, this is good. This will work. This is, you know, we can deliver this. What else do we ask them to do? So we'll ask them for permission to look at their clinic chart, their hospital charts. There's a couple of phone calls. There's an online questionnaire. We interview them after the pregnancy, and there's that home or study center visit. So as I outlined, so that's the extent of their participant burden is that. So now I'm going to talk about the outcome, which is kind of it was an interesting debate that we had. So the nice thing about composite outcomes is that you're taking a lot of different outcomes that they need to all go in this, like, ideally in the same direction, because you don't want composite outcomes to cancel each other out. So they all have to be like, if you're looking for bad things, okay, they're all bad, or you're looking for good things, they're all good, but you're kind of collecting them. The problem with them is that if you just take them as a whole group, and then you say, okay, if you get any of, then you will really, like, it'll all rely on the most common outcome, and you may lose the flavor of the more serious outcomes, right? Because if you're looking for GDM, but then, you know, somebody had a very complicated delivery and a bad outcome, that person's counted the same as the person who had diet-controlled GDM, right? So that's the challenge. So the more severe but rare outcomes are not captured. You know, you could capture them, but they're not reflected in the same way. And everything's kind of ranked equally. So this is this approach that we're going to use is a ranked composite. So you have a composite, but you rank the order of severity, knowing that the less severe are going to drive a lot, but you're doing an upfront ranking, and you always count the most severe outcome first. So how do you do that? So for example, this is our primary ranked composite. So the most severe is somebody died. So stillbirth, neonatal death, maternal death, all bad, somebody died. Next severe, we're grouping as preterm delivery. Then an inappropriate size for gestational age. So you notice I didn't do small or large because those are like mutually contradictory. So it's either, because it's not good. Then gestational diabetes or gestational hypertension or preeclampsia, and then none of the above. So that's the ranking. So how do we do that mathematically? And we do have an expanded composite, which is harder to do your sample size on. So this is more exploratory. We have finer sort of differences between the two outcomes. So we analyze it using a win ratio approach. And this is a method developed by the group that I've just cited there. And the interesting thing is, I've been interested in the win ratio. And so we had Stuart Pocock give a presentation virtually like months before, like a year before, because, you know, journal club, like one thing leads to another. So we had invited him, and Nadine DeCurry invited him on our behalf. She's a statistician, and he gave a great presentation. But then, as many presentations go, I promptly forgot about the presentation. And I was just talking about a composite with a colleague of mine, Patrick Lawler, who's a great clinical trialist at the NHC. He goes, yeah, composites. They can be problematic. I go, wait, win ratio. So then I emailed them and I said, would you join us on the trial? And they said, sure. So that, you know, that was very, very helpful. So what do? So with the win ratio, you have your control arm, your intervention arm, and you compare every control arm participant to every intervention participant. So it's a pairwise comparison. So everybody's getting compared to everybody. And so the pair is like a match, a contest between the two of them. And so if the better outcome, so in this case, not having the outcome, happens in the intervention arm, that's a win. So we won the pair. But if the worst outcome happens in that pair, it's a loss. So you get your wins and your losses. And you start at the top. So did somebody die? Someone died. Which group? Win or loss? Nobody died. It's a tie. Go to the next level. And you keep going down until you get to the no outcome. So you do that. And then you add up the wins and add up the losses for your intervention. You take the ratio, and then there's a software to calculate the 95% confidence interval for that. And so if you go to our core, it's called the core TV. Yeah.
We should go back to the previous
Yeah.
slide. Do you weigh differently based on the hierarchy of the outcome that you're comparing them to?
You set it. No, well, you have your hierarchy of the outcome, and then you set what the rules of the game are within that. So it could be something simple as death, no death, and then you win or lose. And that works here because it's a short time. But if it were another condition where there was a time to event, then you would do it by time to event. So who, if they had the event, and if they both had the event, who had the longer time to event versus the shorter.
But so you go down until you're able to declare a winner or loss, right?
Yes. Yeah.
So
Or
if-
tie.
Or time.
Yeah.
So if you're able to declare that at the very top, death.
Yeah.
Which is a major thing.
Yeah. You stop there.
Versus if you have to go all the way down to skin rash.
Yeah. Yeah.
Which is not the same impact
Yeah.
as death. Is
Yeah.
there different?
Is it weighted differently?
Yes.
It's not weighted differently, but as I'll show you, you report where your wins and losses happen at every level. So in the end, when you summate, it's not like you ranked that differently. But if you had death and you had GDM, it's the death that counts, not the GDM.
Okay, so it comes back in some sort of hierarchy. Then.
Yeah. And then later on, you'll see you do. So this is just an example. So A wins on. So this is the follow-up period, and then you can, A wins on death in those different scenarios. And so, for example, in the second example, even though there's a hospitalization, it's not the hospitalizations that's driving the outcome. So A wins on death, and then later on A wins on hospitalization because no one died, or there may have been tied or no winner. So it's just to show you the follow-up periods and how you manage that. But to get to your question, Ari, so what they'll do is what's done is kind of a reporting like this. So at every level, you'll know what was the proportion of wins, what was the proportion of losses, what was the proportion of ties. And then you calculate your ratio. And then you can also calculate your win difference. So kind of like the absolute difference between the two. So it can be quite transparent. And it's an interesting literature. So they've done reanalyses of trials sometimes, and trials that looked like they didn't, let's say, have a clear result related to their primary outcome might have suggested an intervention was better based on, for instance, a quality of life measure that was further down. And then you'd have to make a whole other set of decisions around cost effectiveness and so on to decide.
So in this example, you have rivaroxaban with aspirin versus aspirin alone.
That's
right. And I think in the original trial, it looked they were very similar, and this is showing that the rivaroxaban plus aspirin is actually more beneficial than aspirin.
That's right. Yeah, exactly. Yeah. No, very good. Yeah, exactly. So so you can sometimes pick up subtleties you might not have otherwise. Everybody's a pair with everybody else. Yeah. It's kind of like
It's not like I'm like in like it.
It's not a
done
fixed
in
pair.
that.
Everybody. That's why it's multiplied there. See, because those are the two arms. So that's the number of pairs. So basically, I mean, that's pretty much it. So we're trying to test a simple, scalable intervention. I think we're addressing a gap in clinical care tools. Because I didn't get into it all that much, but this has been one of the main areas of research that we've been doing, where it's step counting Now people know about Fitbit. When we started doing step counting, nobody knew about it. Like we were doing it a long time ago. And, we did the smarter trial and showed that if you count steps in diabetes care, you can increase activity, and you can, if you prescribe them, and you can increase activity, and you can reduce A1Cs. We're planning to do it here in pregnancy. We've done it in GDM, shown an effect. We're doing another trial, Partner Step 2D, where one person has type 2 diabetes, the other one may or may not. Both couple members get a step counter, but half of them also get marriage counseling. So to communicate that. And we're looking at that, in an older age group. So we've done a lot of work in step counting as a deliverable method. And then we've done more intensive exercise in different populations. We just finished our big Canada-UK trial, looking at an intensive exercise intervention combined with a low-calorie diet for diabetes remission in young adults, and got some fantastic results from that. So, but I think the bottom line is the type of physical activity intervention you pick depends a little bit on the trial population. So you're not going to put a bunch of pregnant women into, or pregnant people into, an intensive boot camp. Like, that's not happening. And so, unless they were already doing it, God bless them. That's what it was. So that there, the step counting makes a lot of sense in older populations, and perhaps in younger ones who are not pregnant, something more ambitious. But so we're waiting to hear back from ethics, and then we're hoping, by summer we'll be able to start. And once we get going here in Montreal, we'll eventually start on our other sites. That's it. Open up.
Let's open it up for questions. Those of you who are on the Zoom, just use the hands up feature. N'hésitez pas à utiliser la fonction lever la main si vous avez des questions. While people think of their questions, Ajna, can you tell us about the weekly prompts, the content? Is it personalized to Jane Smith, 23 years old, slightly overweight, or is general aspirational things, eat better, walk more?
Yeah, it is general aspiration. It's focused more on the walking, so a bit specific. There are messages that we've created because we are OCD and somewhat risk averse, and so we will not use AI at this point. Refuse to right now. So they're not individualized, but they're tested messages that we've used. That's a good question though. Yeah. We've constructed it as something that's very deliverable without a lot of bells and whistles. So we're not going to get they don't have to, other than the Fitbit app, which is required so that they transmit the steps. Even that, when we get them to download it, we remove anything that could be identifiable, and we provide them with the Gmail address that we've created that's different from their, normally an address will include your name and so on. So there's nothing of that. So then they can look at their patterns and so on. If they choose to use the little badges, it's up to them, but we're not doing, we're just, sort of setting the targets, sending them the messages, prompting them to use it. So it's important, if you use it, you have to make sure that it downloads to your phone so that we can pull the information to send the next week's target. So, if we find that they're not using it, we've refined our back-end system to be able to track that, and we will call them and find out, is there a problem? Is it technical or otherwise? Some of those things we worked out in the course of the feasibility trial, so we gained a lot of experience with that. And if in the end it works really well, then we may build it into an app that others could use and just download. But for now, we're kind of maintaining control over what happens. Yeah.
And I was wondering if you are looking at other adults living in the household. We had a talk recently where there was evidence that other adults living in the household had influence on geriatric outcomes. I don't know if you're thinking of looking at what's going on.
So we were not, because that would, right now, because it would add complexity to the trial. We've done work, though. I've done a lot of work epidemiologically on a couple concordants, and that's actually why we're doing the partners type 2 diabetes trial. So you're absolutely right that families share risk, and there definitely can be influences. Those similarities or differences, hopefully randomization will take care of it to some degree. And we may ultimately embed other studies with, students as we go along, but for the right now, we're not. But you're totally right that physical activity behaviors, eating behaviors are shared in family. Not only are they shared between parents and kids and within the couple, there's also evidence for diabetes in dogs and their owners that, weight. And that was published in a BMJ issue like a few years ago, their Christmas or holiday issue. So yeah, the environment can have a big role. Yeah.
Questions?
So, I've been involved.
Yeah.
Let's get a moment.
Multiple of the studies over time. And actually, I'm going to be honest, when I initially already had seen this study, I thought I automatically was thinking about partner step 2.
Yeah.
In my notes, I can show you. I actually had written the title of my little folder is actually pregnant step 2D.
Yeah.
So I've already progressed into the future.
That's right.
So
yes.
I'm just wondering in the ethics proposals and things that we have feasibility is to add in just a little line of collecting data on the partner, because it would allow us to actually go back into this data and pull out partners.
So I think
if they have a partner and so on.
Yeah. So problem with those little lines is that they're never a little line.
Yeah.
So there's a lot of it. We've done it, and we've done it in other studies. There's a lot that goes with it. So one is a question of consent of partner, and their data. And so I think in my experience, it's better to kind of get the approval, get it accepted overall. And then you can do a modification.
Yeah, that's exactly right.
Yeah.
A modification.
But if you upfront do that, it will delay you understandably, because then they'll say, well, how's he? Yeah. And then it becomes a whole other yeah, what's fun about this kind of thing, but also kind of challenging is we also have lots of collaborators, and everybody's got amazing ideas, and they're just kind of looking at us like, why can't we do this? They're like, wow.
The biggest challenge with this.
Yeah, exactly. Yeah.
Who's the patient?
Yeah.
The pregnant person.
Yeah,
The other
exactly.
person is nothing to you as a clinician.
Yeah.
Therefore,
you can't pull them in necessarily.
exactly.
Yeah.
So
Yeah.
it would be a nightmare in
Yeah.
terms of R&D to send it back and forth for months and months.
But we got the partner step 2D was accepted. And we have it, and we just had a meeting just before this to give you some of the first patients from St. Mary's. Medicine. So it's possible.
It's possible. But one of the interesting things that we are finding in Partner Step 2D, which was not really a challenge that I anticipated. This is off topic, and it's not this one. So I do my diabetes clinic every Friday. It's very specific. You would think I could recruit a ton. I can tell you the number of single men I have in front of me. and genuinely. And then I have some women who've lost their partners. And then I have, and at the end of it, and then I have some people with major comorbidities, so I can't take them in. So I'm kind of, this was enlightening for all of us, because, we think, okay, the partner is the logical, person to support. And then you discover, wow, there's something about, the situation, the demographic. So I think it's going to be important. It's going to be an interesting study, but that does remain a challenge. And then for, pregnant individuals, I think for sure as a sub-study, we can do that for sure. But, again, it will wind up being maybe a little bit more of a selected group, because not everybody's partner is going to be into it. We'll have to decide, is it going to be just sort of passive, that we just want them like the controller to wear it a few times to understand the ripple effect, which has been described quite well, that, one person starts, moving, the other one does. But then the difference with Partner Step 2D is we're trying to get both of them to move, and they may move together. Here, we have one person who's pregnant. So their activity level is likely to be, not always, but perhaps quite different from their partner. So I also am sort of mindful. I don't want to set up a situation of frustration. So, at least they're not part of the intervention, but I would be interested to know, what changes, do they increase a bit? Yeah.
It brings us back to when we had a long time ago, we had a research program looking at group prenatal classes. And so I can imagine in future group sessions where we give step counters to 2 pregnant people and then see if they're in,
And they get partner.
I have ideas. I already mentioned
Yeah.
that.
But I think that's the key is, like whoever knew we'd have to engineer physical activity back into our lives. Like, I mean, when I was younger, I remember when I first moved to Montreal at 20, like I had to run around all over the place. Had to go to the bank, had to go mail letters, had to go have like constantly, like you didn't have to try. Now, geez, you could just sit there and God help you if you want to speak to a human being. So, it's a very, very, we've engineered physical activity out of our lives. Now we're going to engineer social interaction out of our lives, and then it'll just be AI doing everything. So hopefully not. I mean, this is what we're trying to avoid, but yeah.
That's an interesting outlook.
It is. But I mean, I think we're sort of stuck trying to oppose, that kind of a trend, and there will be some people, honestly, that are there are already people who track and they're mindful, and all you really need to do is give them a step counter, and they'll start to think about it. But many of us like getting a little, oh, what should I be? Oh, I should be doing that. Okay, let me try. That can be helpful. And it's that group we're trying to get. There will also be people who want to have none of it, but that's like every therapy we have to offer, right? So yeah.
I'd like to flag that there was a question in the chat.
Oh, yes. Tell us.
Ouais, click on arrêter le parcours.
Yeah, you could. No, that's good.
How do you take into account the socioeconomic factors? Walking 6200 steps in a South Shore park is different than walking Montreal's traffic filled, dangerous pollutants, potholes, I'm going to add, with deleterious effects on health.
Well, it's interesting. It's a good question, and for sure, living is dangerous, and we breathe all kinds of things. There's no question about that. Although the literature would generally tell us that people in Montreal have more opportunities and they walk more than people in sort of more suburban areas. So there's a lot of good work on neighborhood walkability, for example, and walkability is related to kind of the old style neighborhoods, like literally Côte de Neige. It's pretty walkable. And why? Because there are sidewalks. There's a lot of reasons to go, right? People often need a reason to go out. So, you'll go for a coffee, or you may not mail a letter, but maybe. And so you'll go, buy a stamp, or you'll go look at the bookstore. So that's not so much socioeconomic. It is like where you live, but and depending on where people are living. So that again, our catchment areas are our catchment areas, and there will be people living in different zones. But people are not necessarily walking in a park. The literature actually says that incidental walking or walking with the goal is more common, and more sort of dense, diverse areas tend to be more. And then car ownership, which can be a marker of higher socioeconomic status, kind of is inverse to walking. So people with less means may walk out of necessity, not necessarily, but that can happen too. So the reasons and opportunities for walking are not straightforward, a socioeconomic spectrum. It's probably more of a U or otherwise, so that is a factor. And so it goes a little bit to why we pick walking too, as opposed to something else, because there's not equipment involved other than a good pair of shoes. There are safety issues everywhere, but they're not horrendous.